and the progesterone. Thank you.
Yeah. Thank you for your kindly introduction. And thank you, ESHRE, to giving me this opportunity to see the beautiful Paris and to say an overview about the topic of progestin prime ovarian stimulation, comparing the array suppression efficacy of oral micronabrogesterone and dydrogesterone. I have no conflict of interest regarding this presentation. And as we all know, we are all familiar with the antagonist, which is considered by most the gold standard for controlling the LH surge during ovarian stimulation. And from COVID-19 pandemic until now, the PPOS are being increasingly used in physio protocol. And PPOS using the oral progestin to suppressing the premature array surge instead of using the antagonists, which are only available as a subcutaneous injection, so it can bring the patient more convenient, like fewer injection, less pain, or easier to use, while patient only need to pay the lower medicine cost. However, when using PPOS protocol, it is necessary to physio MBO. But with the advancement of vitrification technologies, frozen embryo transfer is no longer a concern, but it is regimen effective. So many studies have been conducted and have shown the same result that the array concentration during ovarian stimulation using PPOS was well controlled, and the number of oocyte, major oocytes, cleavage, and platocyst embryos were comparable between the two protocols. And the frozen embryo transfer outcomes of two protocols seem to be similar in terms of both ongoing pregnancy, labor rates, obstetric, and prenatal outcome. And the last draft version recommendation from the ESHRE, which is ovarian stimulation for IVF-HC, proposed that if a physio is planned, the use of progestin for pituitary suppression is probably equally recommended to GNA analog. And there are three common oral progestin was used, and they are MDA, dydrogesterone, and microgesterone. And while oral micronabrogesterone not only inhibit the array peak, it also act on the GABA-A receptor through two ways to improve the sleep quality, and only oral micronabrogesterone had this effect. So that's why we conducted a study to compare not only effectiveness of oral micronabrogesterone and dydrogesterone, we also compared the sleep quality through the Pittsburgh Sleep Quality Index. Our objective is to assess the comparative efficacy of oral micronabrogesterone and dydrogesterone for array suppression during ovarian stimulation in women under 14 undergoing IVF-HC. And our study is a retrospective cohort study in IIT Center Tâm Anh General Hospital in Vietnam from August to December 2024. Our patients were in study if their age under 40 and undergoing IVF-HC. Their basal FSH also less than 10 units, and the ovulation stimulation using PPOS protocol with either oral micronabrogesterone and dydrogesterone. And the exclusion criteria is a patient have PCOS syndrome or ovarian tumors, surgical sperm retrieval procedures, egg donation, or oocyte freezing. The eligible patients will be given dydrogesterone 30 mg per day divided 3 times per day, or using oral micronabrogesterone, just single tablet of 200 mg at night before go to bed. And we will collect at the first day of stimulation, we will collect the basal FSH, LH, estrogen, progesterone, antral follicle count, and PSPI. The average level will be measured on day 6, day 8, and the day trigger of stimulation. The PSPI also be evaluated at the day trigger, and the patient will switch to another protocol if their average concentration increase abnormally. Our study have a total of 110 patients were eligible, including 55% in group 1 using dufacton and 55% in group 2 using utrogestan. 50 cases were switched to antagonist protocol, including 5 cases in group 1 and 9 cases in group 2. And this is our result. There was no significant difference between baseline characteristics between two groups. Also, no difference between two groups in characteristic of cycle, especially in the terms of total gonadotropin dose, number of stimulation days. We saw that there are 2 cases have the symptom of OSS and just only bloating. They are all in group 2. No cases had OSS symptom in group 1. Interestingly, this is what we see in LH hormone concentration were significantly higher in the micronibrogestrone compared to the dydrogestrone. About the, there was no difference between the two groups in the number of oocyte retriever. Oocyte exceed the 4 OSI index in the good embryo in day 3 and day 5. And the same result in when we analyze in the subgroup statistically. With the ESHRE, we using classify that if the patient have less than 5 scores, so they associated with the good sleep quality, and if they have more than 5, they associated with the poor sleep quality. And there was no difference between the two groups in ESHRE scores. However, when observing cases with actual sleep disturbances, micronibrogestrone showed greater improvement, which is a higher ESHRE score, the better micronibrogestrone effect on improving sleep. To conclude, the LH concentration during the ovarian stimulation cycle was significantly higher in the micronibrogestrone group than the dydrogestrone group. With ESHRE, although it tended to be decrease in the micronibrogestrone group, the reduction was not statistically significant. And the rates of oocyte retriever, good quality embryos were comparable between the two protocols. No cases of moderate or severe ovarian hyperstimulation syndrome were observed. So I have this opportunity to acknowledge my supervisor, my colleagues, and thank you. I'm happy to hear your opinion. Thank you.